It's a very, very great privilege I have to introduce Dr. Jeannie Trigestad. Dr. Trigestad, I've come to know with her work on the Human Growth Foundation board. The PESTOLA board of directors. So her input on all of the meetings, including this one, have been extremely helpful. And in addition, I think she's an extremely talented person in terms of, her body of work as a physician. She has a very strong research background and has been involved in numerous studies in type 2 diabetes and collaborations across the United States. And I think it would be fair to say that you're an expert in type 2 diabetes and comorbidities. So with that, I want to introduce her, and she's going to be talking today about diabetes-related complications and comorbidities in youth. Thank you.
Thank you, Dr. Stillman. That was a very kind, very kind introduction. As he said, I have been involved, and I'm specifically going to talk about some of the outcomes today from the Today study, which is really important for most of us here in the PESTOLA region. I have to give my disclosures. I have no financial disclosures. We'll talk about one investigational drug in the context of the Today study. So what I want to start out with is just giving you some context for type 2 diabetes in youth and how the prevalence has changed over the last 20 years. We're going to describe how it progresses and how aggressive youth onset type 2 diabetes is, and then really try to look and recognize some of the complications that arise and how quickly they can arise. So to identify a few practice gaps, I think many times we fail to recognize that in youth, especially, we need to intensify treatment very early and very quickly. And we may not know the rates in youth. And so I want to share that with you today. And I think there's some of us that forget to screen and forget to screen early. So I want to kind of impress that upon you today as well. So let's talk about the prevalence of type 2 diabetes in youth. And we've all seen this search data. We're very familiar with it. And again, this was looking at the prevalence there on the left. You see the prevalence of type 1 diabetes. And we can see, again, we see some in the very early ages and then increases as we see those peaks through childhood and early adolescence. And for us, it's the racial and ethnic background or breakdown that we expect, such that in type 1, the preponderance of the prevalence is in the non-Hispanic white population, with less that we see in the racial and ethnic minorities. We're contrasting that with what we see in type 2 diabetes, which is that figure there on the right, where you do not see type 2 diabetes before the onset of puberty, very, very rarely. And that's why you see such a small number there in the 5 to 9-year-old, those that have those early onset of puberty, that's maybe where we see it. And then it increases as we go through the pre-adolescent and adolescent time. And again, we know that racial and ethnic minorities are at higher risk for developing type 2 diabetes than their non-Hispanic white counterparts. If we look at breakdown of type 1 versus type 2 by racial and ethnic groups, you see, as we expect, type 1 diabetes is the predominant form of diabetes in non-Hispanic white. As we move through there, the non-Hispanic, Black, Hispanic, Asian Pacific Islander, we see an increase in the percentage of type 2 diabetes as a whole. And with the American Indian, Alaskan Native group, we see that the preponderance of diabetes in this racial group is actually type 2 diabetes, which is a big issue for us, especially here in Oklahoma. This is, again, some of the search data looking specifically at type 2 diabetes in youth. Those first studies in the area, and this one is extended out to 2012, and we can see that over time, this is incidence instead of prevalence, or new cases that were pretty static in non-Hispanic white, but in all other racial and ethnic minority groups, there was an increase over time, and some, especially non-Hispanic, Black, and American Indian, a pretty steep increase with time. Again, one more piece of search data here, which is the last study we saw ended there at 2012. This is extending then on to 2016. And we can see through the years incidence, so new cases of type 1 are increasing, type 2 are increasing faster. And at least there's one prediction out there that by somewhere around 2050, 2060, the incidence, the new cases of type 2 diabetes will actually surpass the new cases of type 1 diabetes. So we have a problem. Let's look now a little bit at studies of type 2 diabetes in youth. And I'm going to really focus my attention here on today's study, and just because we were involved with that here in Oklahoma, but not only Oklahoma, but we had sites in Texas as well. And I'll show you the map here in just a second. So why did the Today study even develop? Well, because we knew that there was this increasing prevalence, increasing incidence of type 2 diabetes in youth. We knew that the risk factors, specifically obesity was increasing as well, leading to more cases of diabetes. And there were no large-scale studies in youth to look at what was the best and effective treatment for type 2 diabetes in youth. And there was a systematic approach that was needed. So the 15 clinical sites were developed. And we can see here Oklahoma, San Antonio, and then Baylor as well. So the PESTOLA region was well represented within the Today study. I do want to give special recognition, especially for our Oklahoma site, because a part of our success in the Today study was our partnership with our Native American partners. And we were able to partner with the Chickasaw Nation, the Choctaw Nation, the Cherokee Nation, the Absentee Shawnee tribe, as well as Oklahoma City Area Indian Health Service. So just wanted to give them recognition there. So just to remind really quickly what today's study started out with. So this was 699 participants. They were randomized into 3 treatment arms, one of them being metformin alone, another one being metformin with rosiglitazone, which again was approved in adults but not in children. And then metformin plus a very intensive lifestyle arm. And this was like very intensive, like meeting with a pal, meeting with a person weekly, and a very intensive intervention. And the primary outcome here was time to treatment failure, which was defined as A1C greater than 8, or inability to wean from insulin after a metabolic decompensation. And so what you can see along the timeline there is within 5 years of this study, we had almost 50% of them fail. That's a fairly short period of time to fail treatment. And the effect of the treatment groups, we do see here that compared to metformin, the metformin plus rosiglitazone was actually superior in preventing treatment failure, but was not any different than the lifestyle. And the lifestyle was really no different than metformin. And so we knew that we needed something more, and are still working toward that. What we did see in Today, and this is looking at the first 3 months after they were randomized into the trial, we can see here in the blue those that did not fail. This is the oral disposition index, which is a measure of beta cell function or insulin production relative to insulin sensitivity. And we can see that it was preserved in those that did not fail. Beta cell function deteriorated pretty rapidly, and leading to the cause of treatment failure in the groups that did fail. So after the Today study was over, we went into an observational phase, which was wrapped up in the last 2 years, where the goal was to really look more at the complications, mostly microvascular, but a few macrovascular complications related to type 2 diabetes. So again, just a quick review: macrovascular disease is the leading cause of morbidity and mortality in diabetes. And cardiovascular disease is the leading cause of death in patients with diabetes. And we know that about 2/3 of deaths in people with type 2 diabetes is related to cardiovascular disease. And other risk factors, hypertension, hyperlipidemia, arterial stiffness, we can all see this as complications that arise in type 2 diabetes as well. In macrovascular disease, according to the nephrine disease, this occurs in about 20 to 40% of patients with diabetes. It can be present at diagnosis, and we did see it at diagnosis in the Today study. It's the leading cause of end-stage renal disease, and we know that if you have nephropathy, that increases your risk for cardiovascular disease. Retinopathy, again, leading cause of blindness and strongly associated with diabetes duration, as well as the glycemic control over time. And the nephropathy, and nephropathy really comes in several different groups. We have the peripheral nephropathies, autonomic nephropathies, and then the GI or gastroparesis as well. And again, glycemia seems to play a key role in stopping the progression of nephropathy as well. So let me take you back. This is from some studies of complications in youth, and where they looked at youth with type 1 versus type 2 diabetes. This is from a cohort in Canada. There were 342 individuals with type 2 diabetes and about 1,000 with type 1 diabetes. And you can see there, when you compare the two groups, any complication was slightly higher in the type 2 diabetes, but you see specifically that they had more renal complications, specifically, and neuropathy. Retinopathy there is the only thing that was a little bit higher in the group of type 1. If we look at the search data, and this is looking at data back from 2002 to 2015 within the search trial, and they had, real quick, they had about a little over 1,700 participants with type 1 diabetes, and then let me get the number for the type 2. There was about 272, and so this is looking at specifically the percent of those with complications at the age of 21 in search, so that we can see that about 20% of them had some sort of kidney disease. Retinopathy about 10%. Peripheral neuropathies, they're at about 18, with cardiac autonomic neuropathy, they're about 16 to 17 as well. Arterial stiffness was seen in quite a significant number of them, as was hypertension. So if we look at what we saw in Today, and we're looking at the blue bars there, you see at baseline. And then at the end of Today, so that was that first 5 years in the study, the clinical trial, and we can see that LDL dyslipidemia doubled. Hypertriglyceridemia was common in the beginning, and was still common. Hypertension almost tripled within those 5 years. Nephropathy, again, I mentioned you could see it at baseline, and this was about 7% at baseline, that again, a little over doubled by the end of the study. And really, there was no retinopathy at the beginning of the study, but again, it was about 15% of those in the study by the end. So looking really quickly to remind you the timeline in Today, we see again that the actual recruitment of patients there started in 2004, and the clinical trial went from 2004 to 2011. They had visits where they got medical history, A1Cs, things like that, and then annual visits for nephropathy and kidney function. And at the end of Today, they were able to obtain an echo and a fundus exam with the OCT photography as well. We then Today transitioned then in that 2011 to 2014 time period. And this is where they were no longer randomized. They went on to standard treatment with metformin or metformin plus insulin if they were experiencing treatment failure, and continued to follow the sites about every 3 months for visit with annual nephropathy visits. And then in 2014, so from 2014 out to 2020, we continue this observational phase. So the participants were fully transitioned into their community providers, but they continue to have annual visits with us for for a complete medical history, neuropathy, kidney function. We were able to look at arterial stiffness during that first phase of the going into the observational phase. And then in the fully observational phase, we were able to repeat the echo, which was about 5 years later, the PWV about 5 years later, and then the fundus exam about 7 years after the first exam. So now I want to take a little bit of time to look at specifically some of those cardiovascular measures that were examined and what they look like. So as I mentioned, in that first phase, we looked at pulse wave velocity. So this is some of the readout from there. And so the carotid femoral is kind of the central stiffness, and we see that as compared to lean controls, the participants in today, about 50% of them actually had abnormal stiffness. So their vessels were more stiff than the lean controls. And if we look at the carotid to radial and the femoral to foot, some more of those peripheral measures, they were again about 30%. And then the aortic index and breakdown are another measure of arterial stiffness. And again, we see that overall they're more stiff in this group, which is again a risk factor for future cardiovascular disease. At the same time that we were collecting this arterial stiffness data, we were also collecting heart rate variability to begin to look at cardiac autoneuropathy. So what we're looking at here, this is the standard deviation for the end-to-end, so the beat-to-beat variability. Higher beat-to-beat variability is better. So in our participants from today, which again they're in their early 20s at this particular time, even compared to obese controls, they had significantly lower beat-to-beat variability. Again, higher risk for cardiac autonomic dysfunction. And this is just the root mean squared, which, so again, a lower number is worse. And this is the beat-to-beat for 50% of the time. So again, lower. When we look at these low power and high power numbers, this is looking at what is the autonomic control. So ideally, this should be parasympathetic control, which you can see here in the high power. That's the parasympathetic control, which was lower in the today. Low power and the low power to high power is suggestive of sympathetic overdrive. And we can see by the higher numbers here with the low power and the low power to high power ratio that we have more sympathetic overdrive in our youth from today, again, suggestive of this cardiac autonomic dysfunction. So as I mentioned, there were also echocardiographic findings, and these were looked at initially and then about 5 years after. And this was a comparison of normal weight controls, obese controls, which are about the same age, and the obese controls are about the same BMI as the type 2 participants. And what we see here is we're looking at cardiac geometry and mass. So everything was normal in the lean controls. If we look at those obese group, we see that they had normal wall mass, but had a little bit of hypertrophy. That's the high wall. So that's 1.6. And then if we look at those that just had the increased mass, there was about 3.6. And if they had both, about 0.5. So overall, there were still about of those that were obese that had normal echo findings. In contrast to those with our participants from today with type 2 diabetes, and we see that only 84% of them had normal echo findings, and this again is in their early and mid 20s. So we can see there that about 5% of them had the abnormal mass, about 9% of them had the hypertrophy, or excuse me, 5% had the hypertrophy, about 9% had the increase in mass, and 2% there that had both. So again, significant cardiac findings along with the autonomic and the stiffness, all making this showing that these kids are at really high risk for cardiovascular disease. When we look there at the end of today, we're looking at incidence of complications, and we can see that hypertension at baseline was about 20%. Cumulative incidence through the 15 years of follow-up was about 68%. If we look at dyslipidemia, so this is including LDL dyslipidemia and We can see at baseline, it was about 20%, a cumulative incidence of about 50%. If we start to look now, we're going to transition toward talking about more microvascular complications at this point. So again, the baseline prevalence of any microvascular, so this is going to include nephropathy, retinopathy, and neuropathy. And of course, we didn't have any retinopathy at baseline. Was about 9%, with a cumulative incidence of 80%, and such that it was almost 60% of participants had at least one microvascular complication by the end of the study. And again, the average age was about 26 years and within about 13 years of diabetes duration. If we look specifically at kidney disease, so this is including microalbuminuria and macroalbuminuria, the baseline prevalence was about 8% and cumulative incidence of about 55%. And when we look at some of the specific forms of nephropathy, we can see that that's the urinary albumin to creatinine ratio that was greater than 300. So this fits into the macroalbuminuria category. We don't see any difference per se between the male and the females. There's really no difference by race, ethnicity as well, although maybe here out toward the end there might be a trend toward developing. If we look at the microalbuminuria, so that's the greater than or equal to 30. Again, no real difference between males and females. Again, no difference in race or ethnicity till you get out here toward the end, and then we might start to see a trend and start to develop. But even prior to the development of microalbuminuria, you can start to see hyperfiltration. So hyperfiltration is, again, looking at the estimated GFR, and the natural course in this is that it increases and then falls. So hyperfiltration in itself is a marker of future disease. And again, we don't see it's borderline difference here with females having slightly higher rates of hyperfiltration. However, there does seem to be a significant difference in that the participants with Hispanic ethnicity had a much higher incidence of developing hyperfiltration as compared to the others. And again, we were seeing there at the end how you could kind of start to see the trend start to develop. So if this was carried out further, what we see with hyperfiltration, we may easily see with microalbuminuria and then following it with macroalbuminuria. With nerve disease, again, at baseline was about 1%, and then the incidence being about 30%. If we look at retinopathy during the study, so again, the fundus exams were done in about between 2010 and 2011. Then that photography was repeated again between 2017 and 2018. And at the first reading, you can see there the vast majority had no diabetic retinopathy, and a very small number that had very mild non-proliferative diabetic retinopathy. However, in about that 7-year time span between the two, we see a pretty dramatic rise in very mild non-proliferative retinopathy, but also non-proliferative diabetic retinopathy, as well as moderate or worse. Here in the panel B on the right, this is macular edema, which again, no one had macular edema at the beginning, but we did see small percentages start to increase there 7 years after that had already developed macular edema within that 7-year period. So when we look at microvascular complications, looking at the kidney, the nerve, and the retina all together, and we could see that there were overlap. And of our participants, we actually had 48 that had all three complications. You can see there that there were still roughly about 140 that had at least two complications as well. And then if we begin to look at the timeline for the development of these complications. In the participants that had one complication, on average, that complication developed about 6 years after the onset of type 2 diabetes. If they had two complications, the first one happened around year 4, with the second one happening around year 10. And for those 48 that had all three, their first complication was again about year 4, the second about year 7, with the third one being about year 10. However, there are outliers. For example, this particular person had all three within 5 years of the diagnosis of type 2 diabetes. So again, this is just trying to show how rapidly progressive complications are in these youth with type 2 diabetes. As we begin to look at the model of what might explain the risk and how these accumulating microvascular complications, we can see there that race ethnicity plays a role, that they were higher in non-Hispanic, the risk was higher in non-Hispanic, Black, and Hispanic. There really was no difference based on treatment. In the adjusted models, and I'm going to fly this out a little bit so you can see it a little bit better. And again, what was adjusted for was race, ethnicity, duration, treatment, several things. We can still see that hemoglobin A1C or increases in that was associated with higher risk, the 1.8 there. BMI did not play. However, insulin sensitivity did. So the less insulin sensitive you were, the higher your risk of developing the microvascular complications. And again, as we might expect, hypertension and dyslipidemia played a significant role in the development of those microvascular complications. So in addition to these studies that we collected and had the participants do, we also did very extensive, detailed questioning into other health-related complications. And I'm focusing here on the heart and vascular and cerebral vascular events, just because that was the committee that I sat on, and I helped to adjudicate these cardiovascular and vascular events. So the participants were asked at each of their annual visit if they had experienced any of these events, and then detailed records were obtained and reviewed with pretty strict criteria on had to be met for each one of the diagnostic criteria. So again, within the 13 years on average of duration, we had 6 participants that developed congestive heart failure. We had 3 participants that had MI for a total of 4 MIs. And we had 3 participants that had stroke for 4 total strokes. Again, the average age of these participants is 26 years old. So again, type 2 diabetes in youth is very aggressive. It's much more aggressive than what we see in adults. So I'm realizing I went through this pretty quickly, but we'll come to some of the questions, and we should have plenty of time for discussion. But again, the takeaway here is that type 2 diabetes, youth onset type 2 diabetes, is much more aggressive in adults. Complications are happening early. I am also pointing out that we had 6 deaths within the Today trial. And again, these participants are 26 years old on average. This increase in beta cell failure and the rates of beta cell decline are what predict treatment failure. And so we really need new treatments, new therapies to try to preserve beta cell function in youth. I'm going to bring up another study really quickly just because I have a little bit of time, and that's the RISE study, the Restoring Insulin Secretion study. This was, again, 5 centers. The aim of the study, they locally developed type 2 diabetes as well as those that had kind of a pre-diabetes picture. And they were either treated with metformin or they were treated glargine for 3 months, and then metformin for a total of a year, with the idea being to preserve beta cell function. And within that year, there was just a dramatic their best. So again, it just shows that we need better treatments. We need more trials to try to understand how to preserve that beta cell, which again will prevent complications and hopefully be better therapeutic options as well. And novel interventions are needed as well, which may be that we need to start planning for this in the pre-pregnancy for moms, and trying to counsel against that, because again, one of the big risk factors that we know that predicts type 2 diabetes in youth was exposure in utero. That's another one of my research passions, so I had to throw that in there. So what do we recommend? So absolutely glycemic control. Anyone diagnosed with type 2 diabetes should immediately be started on metformin at baseline. And then if the A1C increases or at baseline is above 8.5%, they should be started on long-acting insulin as well. Our centers, once we get to 12, we start intensive insulin therapy. And then for those that maybe don't tolerate metformin, or we're especially looking to try to help with weight loss, we'll consider the GLP analogs. And so, of course, Victoza has been approved for a couple of years. Again, nausea is a major side effect, and it's another daily injection. So again, there's compliance issues. We've been talking about compliance some today. And so, last summer, Bydureon was approved. And so at least that way we have a weekly option that maybe will improve compliance a little bit. Specifically talking about screening and treatment for microvascular complications specifically. And those microvascular risk. So screening for dyslipidemia, hypertension, nephropathy, and retinopathy should all happen at diagnosis, because we know that it can exist, and then should be screened at least annually thereafter. We screen for hypertension at every visit. And then we want to treat aggressively, so dyslipidemia with an LDL greater than 120. And of course, starting lisinopril when the urine albumin to creatinine ratio is greater than 30. And again, starting antihypertensives if the systolic is greater than 135 or greater than the 95th percentile for height and weight, depending on whichever is actually the lower of the two. So I'll wrap up now with a couple of thank yous, because we're very indebted to our today participants and their families, because they've provided us with a lot of knowledge about type 2 diabetes, and especially how aggressive it is and the complications that can develop. And we're also very thankful for our coordinating center, because they did all the analysis and helped us with that. And then our core centers I mentioned, and we had an echo, we did the echo, so we had an echo lab, we had the vascular core and several other cores. And then they're wanting to list the funding there for the Today study. And there's my contact information. And so let me stop share now.
Thank you very much. That was very interesting. We have one question queued up here, and for those in the audience, step up to the microphone if you have a question. Before I get to the virtual question, I was just curious, I mean, it's very sobering looking at just how type 2 diabetes behaves so much more differently, when it's diagnosed young. Any theories on why this is the case? Is this genetics? Is this environment? Is it both? I mean, is there any one dominant factor?
I don't think we found the dominant factor. That's a great question, because we've actually looked into some of the genetics. So today, as well as some of the other studies have gone together, and we call a group called Prodigy. And what it was looking at genetic determinants. And while we found some, they tend to lean toward the MODIs, there's nothing that really strikes and sticks out that, this is why type 2 diabetes is so much worse as far as genetic tendency. We haven't really found that. I think the environment is a great question, and I think that's one of the things that we're going to be looking at in the new study, is trying to understand how adverse childhood events, how food deprivation, food deserts, things like that all play into the beta cell function deterioration that happens with that.
Right, I agree. And there's a follow-up question virtually about, just again, to summarize the question, this is essentially about environment and added sugar to foods and how that impacts it. So the gist of the question is, would it be a better use of our time and resources to really go after improving food choices rather than trying to play catch up and manage complications?
And thank you for that. And we do agree. And I think there are lots of efforts that are trying to lead levels. I think most of them are kind of grassroots and trying to take hold. Right. And so I know I do agree with you that there is definitely impact of what we are eating and what processed foods, things like that. Absolutely. It's then becomes an issue of trying to get that in the hands of the participants who live in food deserts, specifically, and trying to overcome this. So, I
agree. I'm sorry, go ahead. I'm going to cut you off.
That's okay. I had pulled up Dr. Wilson's.
Oh, okay. Actually, you can see the questions too. So
I can.
Okay.
So actually do particles in the first phase of today. I don't know that we've done them yet in the follow-up to it. You'll have to forgive me. I don't remember the lipoproteins right off the top of my head. But the paper by Lorraine Lipid's cats is the one that has that data in it. And lipid target and goal for LDL was 100, and trying to target them to less than 100, and triglycerides less than 150.
What about, I have a question. So again, kind of going back to just the data you presented and how it's really scary. So, I mean, I think I'm impressed with presentations that you've done in the past, presentations from other people that are, part of Search or today, getting more aggressive as far as treatment. How do you deal with the fact that sometimes there's a sort of a cultural, resistance to medications? Why do you want to put my child on insulin and all of these medications? Can't we just try lifestyle changes? How do you address that?
So again, it's very relevant. I think we all encounter that on multiple levels every day, especially when it comes to insulin. I think that there are a lot of deep-seated fears about insulin specifically, and a lot of it is from past history in the family that, the last thing that happened was grandma went on insulin, and then, she developed kidney failure when she went on insulin. And so there's these negative connotations that come up specifically with insulin. A lot of what we have to do is when they're saying, no, we want to try lifestyle versus, I come back to my studies and I say, we know that this is so aggressive that we have to be aggressive about it. And so we can't, if I get incredible pushback, we might try it for 3 months. But again, it's if you don't have, if you can't demonstrate, the A1C staying stable, that you're losing weight, that, things are coming, we've got to step up the therapy. And so I think that's part of it, and trying to impress on them that, this is not grandma's diabetes. When we develop it as a kid, this leads to complications fast.
Right.
So you've got to be aggressive with it.
You're going to be cut down as a young adult, when you're supposed to be healthy and active and living life and starting a family.
Yes.
And that's a tragedy. I mean, for us in Peds Endo, we don't necessarily see, we see what's potentially coming, but we don't see, the actual impact of the crash, which you know, it's our goal and our job, hopefully, is to prevent that from happening. So there's a virtual question too. How can you utilize well, heck, you can read it. Sorry.
Here we go. Sorry, I couldn't. Okay. Do you, okay, so honestly, so let me go to the advocacy to communities, and because we've been able to actually share through our local Kiwanis Club, for example, and we've just been able to do different. I actually just presented Grand Rounds to the Choctaw Nation a few days ago, again to try to share their data, and it's just making people aware on a community level and trying to get these out and better. And as far as when we're talking, when I have a new patient when they're resistant, I do give some of the statistics from the result in that, you know, half of people failed on metformin. I hope you don't, but if the A1C is climbing, we've got to be aggressive and treat it aggressively. And so that's a little bit of that. Oh, bariatric surgery.
Dr. Wilson stole my thunder. I was going to ask you that, but okay.
So the data that so there actually was a component, or there were some participants in today that did have bariatric surgery, and they combined them with a larger group of participants out of Colorado and looked at their diabetes. After bariatric surgery, diabetes was better. So it was significantly beneficial for them. And then weight gain, so it's a vicious cycle. Would off-label use be a better? So that is a great question. And the issue is getting off-label covered for some participants. Especially our participants who, because the reality is that the vast majority of my participants with type 2 diabetes are from very low socioeconomic backgrounds. So the vast majority of them have some sort of public insurance, which is very hard to get covered off label. It's very hard for me to get even some approved medications for them without, you know, significant assistance. So until we have the development and the approval in youth, we're forced on some levels to absolutely have to use insulin, which again, it's an anabolic hormone. So you will have weight gain with it. There's just no way around that. And so again, takes more counseling on the front end of, okay, we're doing this, but we've got to use our portion control. We've got to eliminate those sugar containing beverages. I need you to be active. You know, I actually have some patients that TikTok every day, and they've lost a significant amount of weight TikTok. So that's one of my new recommendations. If you have to move, TikTok, it works. So just different things to try to encourage them, since we do have to rely at this point in where we are, we have to rely on insulin for therapy.
I agree. I think, you know, I know we could definitely continue on. I'm going to go ahead in the interest of staying on time, and we'll end your conversation. There is, again, the option for submitting things in the community QA or sending them to us, and we can send them to Dr. Trigstad for answering. So we'll try to continue with that. But thank you again for joining us, and thank you again for all your contributions for PESTOLA, and take care.
Thank you. Same to you, Jill. Thank you.
Bye-bye.
Bye.